So today is the making of third video on of dermatology and cutaneous drug reactions. Actually, this topic is common with pharmacology. Now, starting with what is the just a second most common cutaneous drug reaction. Which one is it? It is maculopapular rash. It is a maculopapular rash. Okay, the most common cutaneous drug reaction is maculopapular rash. There is also a different topic, different whole topic on this maculopapular rash. Now coming to fixed drug reactions. What are they? Now coming to fixed drug eruptions. In this, first of all, let us insert the image of. Sorry, just a second. Okay. Now coming to this. These are fixed drug eruptions. Okay. Now what are they? In this, the patient develops a hyperpigmented macule after taking a drug. Okay. Now in fixed drug eruptions, the patient develops a hyperpigmented macule after taking a drug only. Okay, hyperpigmented macules we can see over here. Okay, after taking a drug, the most common site is lips and genitalia. Okay, the most common sites are the lips and the genitalia. Now, what happens when a patient retakes the drug? The lesion reappears at the same site only. Okay, when a patient retakes the drug, the lesion reappears at the same site, but it usually heals with residual hyperpigmentation. Okay, there is some residual hyperpigmentation. Okay, these were fixed drug eruptions. Now coming to erythema multiforme. Now what are erythema multiforme? This is the example of an erythema multiforme. Now in erythema multiforme, earlier we saw fixed drug eruptions. The first thing that we saw, okay, were fixed drug eruptions. After that we saw erythema multiforme. After this, okay, in this erythema multiforme we have iris lesion, or it is also known as bull's eye lesion or target lesion. We have iris lesion, bull's eye lesion, or the target lesion. It is of two types. The erythema multiforme is of two types: erythema multiforme minor and erythema multiforme major. Okay, in minor there is no mucosal involvement, whereas there is some involvement of mucosa in erythema multiforme major. Okay, till now we studied erythema multiforme, iris lesion, bull's eye lesion, and target lesion were the examples, and it is of two types: erythema multiforme minor and major. In minor there is no mucosal involvement, and major there is involvement of the mucosa. Now what are the causes? The causes are drugs or infections of any kind, such as HSV, mycoplasma. HSV and mycoplasma are the examples of erythema multiforme. Earlier we studied fixed drug eruptions, then we studied erythema multiforme, then we studied Stevens-Johnson syndrome and toxic epidermal necrolysis. Now we are going to study two things, that is Stevens-Johnson syndrome. Okay, Stevens-Johnson syndrome and toxic epidermal necrolysis. Okay, we are going to study Stevens-Johnson syndrome and toxic epidermal necrolysis. Okay, now what is the example of Stevens-Johnson syndrome? I think we missed it. Just a second. Okay, So here are the examples of Stevens-Johnson syndrome. Okay. Now what is the example of Stevens-Johnson syndrome? What happens is when there is intake of the offending drug, then massive erosions over the body is seen, plus there is involvement of at least 2 mucosa. Okay, there is involvement of at least 2 mucosa. That is important. Now this is the image of Stevens-Johnson syndrome and toxic epidermal necrolysis. We can also see that. Now how do we differentiate between these two? In both, massive erosion over the body is seen and involvement of at least 2 mucosa is seen. Now how to differentiate? We can differentiate between them on the basis of according to body surface area. Okay, in Stevens-Johnson syndrome, the body surface area involvement is less than 10%, whereas in toxic epidermal necrolysis it is more than 30% body surface area, whereas SGS, TEN overlap. In that case, body surface area is 10 to 30%. Earlier we studied fixed drug eruptions, then we studied erythema multiforme, then SGS and TEN. Now we are going to study pseudo-Nikolsky sign. Now we are going to study pseudo-Nikolsky sign. This is the example of pseudo-Nikolsky sign. I guess this is the fourth one. Yes. Now what happens in pseudo-Nikolsky sign? Pseudo. Why pseudo? Pseudo because the etiology is different in SJS and or 10. Okay. Pseudo-Nikolsky sign because why it is called pseudo? Because etiology is different in SJS and TN. Now what is the meaning of this sign? Okay. Now first of all, before learning what is pseudo-Nikolsky sign, we'll have to understand Nikolsky sign alone. Now Nikolsky sign refers to the epidermal separation, or we can say skin peeling off when slight pressure or rubbing is applied on the skin. It is particularly seen in pemphigus vulgaris. Okay, when a similar looking phenomena occurs in SJS and TEN, it is called pseudo-Nikolsky sign. When a similar thing is seen in SJS or TEN, then it is known as pseudo-Nikolsky sign. Now why it is called pseudo? Pseudo because the skin peeling as seen in pemphigus vulgaris, it is similar, but the cause is different. Okay, in this case, in pseudo-Nikolsky sign, actually the Nikolsky sign is positive in pemphigus vulgaris, but in pseudo the cause is SJS and TEN, which is drug-induced keratinocyte apoptosis. Okay. Now coming to, now normally Nikolsky etiology is acantholysis. Okay, normally the Nikolsky etiology is acantholysis due to pemphigus vulgaris, PF, and scalded skin syndrome that we already studied in pathology. Nikolsky etiology is acantholysis. Okay, in pemphigus vulgaris, acantholysis. Now acantholysis, where we studied acantholysis. Acantho, was it related to spinosum layer? Let's see, acantholysis. It is the loss of desmosomes. Okay. It was seen in that layer, that epidermal layer in which the keratinocytes, they were polygonal in shape. Okay. Okay, PV over here stands for pemphigus vulgaris, PF stands for pemphigus foliaceus, and this is scalded skin syndrome. Yes, it is usually seen in stratum spinosum. Okay. Now coming to HPE. In HPE there is necrotic keratinocytes. Okay. In HPE we are going to see necrotic keratinocytes in this case. Histopathological examination. Now what is the prognosis? For prognosis we use Scotton scoring. Okay. Till now we studied pseudo. Why is it called pseudo? Nikolsky sign is seen in what, and what is the cause? And in the pseudo Nikolsky sign, what we are going to see in HPE, necrotic keratinocyte, and in prognosis Scotton scoring is used. Now in treatment, stop the offending drug. Okay. There is fluid replacement and there is supportive care is needed. Fluid replacement, stop the offending drug, and supportive care is needed. Now coming to erythroderma. Till now we studied fixed drug eruptions, erythema multiforme, then we studied SGS and TEN, then Pseudo-Nikolsky sign, and now coming to erythroderma. Erythroderma. This is the image of an erythroderma. Now in this case, it is really severe, as 90% of body surface area it turns red. Now what can be the causes? Obviously first cause is always going to be any kind of drugs which reacted. Okay, drugs, severe atopic dermatitis, psoriasis, or Sézary syndrome. There can be drugs, severe atopic dermatitis, psoriasis, or Sézary syndrome. It can happen to any kind of drugs, severe atopic dermatitis, okay, psoriasis, and Sézary syndrome. Now coming to exogenous ochronosis. Okay, exogenous ochronosis. Now what is an exogenous ochronosis? Now what happens in exogenous ochronosis? This is the example of exogenous ochronosis. There is overuse of hydroquinone, which is the drug of choice in melasma. Okay, there is overuse of the hydroquinone, which is the drug of choice in melasma, and more than 4 weeks or higher concentration. What happens? There is darker pigmentation on the skin. Now what happens in exogenous ochronosis? There is overuse of hydroquinone. Now over here the cause is also given, hydroquinone, drug of choice in melasma. Okay, now what can be the cause? Obviously high concentration or taking the drug for more than 4 weeks. It can cause darker pigmentation on the skin. And last but not the least, we have flagellate erythema. Okay, flagellate erythema. In flagellate erythema, there is a whip-like pattern on the skin, and the cause is for exogenous ochronosis, the cause is hydroquinone, and in flagellate erythema, the cause is bleomycin. Now the image is this. This is the image. Now the last one, aplasia cutis. In aplasia cutis, we have absence of skin on the scalp. There is absence of skin on the scalp, and the cause for this is anti-thyroid medication. For example, methimazole. You can see it over here, methimazole. Okay. Now repeating: exogenous ochronosis, hydroquinone. Then coming to the next one, flagellate erythema. It was due to bleomycin. Flagellate erythema, it was due to bleomycin. And last but not least, aplasia cutis for methimazole, because of methimazole. That's all.